Good morning, everybody. Today, I would like to talk about hypercalcemia. First, we will start with the regulation of serum calcium hemostasis. Actually, as we know, serum calcium is regulated in very narrow range between 8.8 to 10.4 milligram per deciliter. And it's regulated by complex negative feedback hormonal pathway involving 125 dihydroxyvitamin D, parathyroid hormone, and calcium by itself. To maintain serum calcium within normal range, we need healthy kidney, healthy parathyroid, healthy bones, and healthy gastrointestinal tract. 99% of the calcium is stored in the skeleton. And calcium comes from the food, and it's absorbed actively by 125 dihydroxyvitamin D. Actually, without vitamin D, only 10 to 15% of the calcium and about 60% of phosphorus are absorbed. With vitamin D, around 30 to 40% of calcium and 80% of phosphorus are absorbed. 125 dihydroxyvitamin D is active form of vitamin D. For vitamin D synthesis pathway, start from the cholesterol nucleus in the skin, and it's converted to vitamin D, then vitamin D, then in the liver, it converted to 25 hydroxyvitamin D, which is inactive form of vitamin D. And in the kidney, 25 hydroxyvitamin D will be converted to 125 dihydroxyvitamin D, which is active form of vitamin D. This conversion from inactive form to active form vitamin D required activation of 1-alpha hydroxylase enzyme, which is present in many tissue, but mainly in the kidney. This activation of 1-alpha hydroxylase required normal level or higher level also from PTH, parathyroid hormone. However, 125 dihydroxyvitamin D or calcium or active form of vitamin D absorb both, increase absorption of both calcium and phosphorus together. So in vitamin D intoxication, we see high calcium with high phosphorus also. On other hand, in severe vitamin D deficiency, we see osteomalacia. There's low calcium and low phosphorus together. Low calcium, as we mentioned, the calcium by itself regulates calcium in the blood. So low calcium will stimulate parathyroid to secrete more hormone, parathyroid hormone, by a receptor which is called calcium sensing receptors, which was detected in 1993. This activation of calcium sensing receptor will stimulate parathyroid hormone secretion. Parathyroid hormone works in the bones. It increases resorption of bone and release the calcium and phosphorus from the skeleton to the blood. And it works in the kidney, increase reabsorption of calcium and increase excretion of phosphorus. So it increases the calcium level and decrease phosphorus level also. Also, we have a rule for magnesium. Chronic low magnesium level will mimic hypoparathyroidism, will inhibit parathyroid excretion from parathyroid hormone, and decrease calcium level and increase phosphorus. As we see, it's this complex pathway. What that means? That means we cannot take decision about the calcium level or calcium status by calcium level alone. Every time we see abnormal calcium level, we have to check parathyroid hormone, vitamin D, 125 dihydroxyvitamin D. We have to check magnesium, also phosphorus, creatinine, and other factors like albumin. Now, serum calcium regulated tightly between 8.8 to 10.4 milligram per deciliter in healthy subjects. And around 50% of this calcium are free ions, which is biologically active. And around 40%, it's a protein-bound complex, mainly albumin and globulin. And around 10%, it's ionic complex. So that means any change in the albumin level will change the total calcium level. So in some diseases cause hypoalbuminemia, like cirrhosis or nephrosis, low albumin will cause low total calcium, but patient doesn't have hypocalcium symptoms because the ionized calcium, it will be normal. It is regulated to keep in the normal range. And in the disease which cause hyperalbuminemia, like multiple myeloma or dehydration, patient, they have high total calcium, but they don't have symptoms of hypercalcemia because the ionized calcium is normal. For correlation between albumin and calcium, for each 1 gram per deciliter albumin, less than 4 gram per deciliter albumin, we have to add 0.8 milligram per deciliter calcium. Also, there's a relationship between the pH stat and calcium level. As we know, chronic acidemia decreases calcium binding to protein, which consequently increase in ionized calcium. And that's what we see in people who have chronic acidemia, like in the stage of renal failure or RTA, that people, they have low calcium level, but they don't have symptoms of hypocalcemia because ionized calcium is normal. Also, on the other hand, we see patients present to AR with hyperventilation. They have symptoms of hypocalcemia, but calcium level is normal because alkalosis, on the other hand, increase calcium binding to protein. So total calcium will be normal, but ionized calcium will be low. So patient present with hypocalcemia symptoms. Also, for correction between pH and calcium, ionized calcium, each 0.1 decrease in pH increase ionized calcium by approximately 0.2 milligram per deciliter. So which is more accurate, total calcium or ionized calcium? In a prospective study, 15 patients with primary hyperparathyroidism and osteoporosis, 6 patients who had normal total calcium, but ionized calcium was high in 95% of the samples. And the remaining 9 patients had intermittent elevation of total calcium. Total calcium was high in 39% of the samples, but ionized was high in 92%. So ionized calcium is more accurate in patients who have primary hyperparathyroidism. A large study compared total corrected calcium and ionized calcium in 691 patients with CKD. Total calcium and corrected calcium had sensitivity of only 20% for detecting hypercalcemia and around 29 to 40% for detecting hypocalcemia. In addition, 7 to 11% of individuals with normal ionized calcium were hypocalcemic by total or corrected calcium. So ionized calcium is more accurate in people who have chronic kidney disease. Till now, the guideline recommend to use total calcium because ionized calcium is costly, is not available everywhere, needs special handling, and till now there is no standard method for analysis. So in general, we use no total calcium measurement. If the calcium level abnormal and we cannot explain the reason, it's better to go and do ionized calcium. Now, hypercalcemia. Hypercalcemia is defined as high calcium level above the reference range. In general, reference range of of calcium between 8.8 to 10.2 or in some labs 10.4 milligram per deciliter. There are 3 states of hypercalcemia. Mild hypercalcemia with calcium between 10.5 to 11.9 milligram per deciliter, moderate between 12 to 13.9, and severe hypercalcemia more than 14 milligram per deciliter. Because of hypercalcemia, around 90% of people who present with hypercalcemia, they have hyperparathyroidism or malignancy. In outpatient, 90% of people with hypercalcemia, they have hyperparathyroidism. In inpatients, around 90% of people with hypercalcemia, they have malignancy. Why there's difference between inpatient and outpatient? Because hyperparathyroidism need many years to develop hypercalcemia, and usually it is mild, so it doesn't cause acute symptoms. For that reason, most of the patients, they come asymptomatic and or with mild symptoms as outpatients. But hypercalcemia associated or hypercalcemia with malignancy usually is acute onset, very aggressive symptoms. Patient hospital. Other reason, we have vitamin D intoxication, we have thyrotoxicosis, adrenal insufficiency, pheochromocytoma, viboma, some medication like thiazide, lithium, vitamin A intoxication, milk alkali syndrome, and embolization, acute renal failure, CKD, and tertiary hyperparathyroidism after kidney transplant. Symptoms of hypercalcemia. The symptoms of hypercalcemia are non-specific and often develop gradually. Severity of symptoms related to severity of hypercalcemia and the time of development of hypercalcemia. As we mentioned, that malignancy, because it's acute onset, people, they need admission and they come with acute symptoms. Typical symptoms include nausea, vomiting, constipation, abdomen pain, anorexia, weight loss, bone pain, polyuria, fatigue, and weakness. In patients with more severe degree of hypercalcemia, usually more than 14 milligram per deciliter, neurological symptoms such as confusion and coma may become more apparent. Now, diagnostic approach. For people who present with mild to moderate hypercalcemia or asymptomatic patients, Usually, first step to review their medication. If there's any medicine can cause hypercalcemia, or if there's vitamin D, it's better to stop it and repeat calcium level after 1 to 2 weeks. For people who present with severe hypercalcemia, more than 14, or symptomatic hypercalcemia, need direct admission, direct treatment, then we evaluate them later. Next step, after confirmation of hypercalcemia, measurement of PTH. Parathyroid level can divide patient in two big groups: PTH dependent hypercalcemia or PTH mediated hypercalcemia, and or non-PTH mediated or PTH independent hypercalcemia. For PTH dependent hypercalcemia, we have only three diseases can cause that. And in this situation, we have normal or high PTH level. In PTH mediated hypercalcemia, we have tertiary hyperparathyroidism, but it's easy to diagnose this case because usually from the history, patient had kidney disease and transplant. Also, we have primary hyperparathyroidism and familial hypercalcemia, hypocalciuria. The challenge to differentiate between hyperparathyroidism and FHH, or familial hypercalcemia, hypocalciuria. Familial hypercalcemia, hypocalciuria is inherited disease. It's autosomal dominant inheritance, and there's inactivating mutation in calcium sensing receptors, which make this sensor fail to respond to high calcium level. And PTH is still secreted by parathyroid even with high calcium. Usually, familial hypercalcemia, hypocalciuria present with high or normal PTH, mild elevation of calcium level in the blood, and low calcium in the urine. This type of disease, it's a benign disease. It's doesn't cause any complication, no need any specific treatment, and usually we have many members in the family, they have hypercalcemia. So same presentation, people, they present with primary hyperparathyroidism, also high calcium, high PTH, low or normal phosphor, but high calcium in the urine. So we can differentiate between them by calcium in the 24 hours urine, and we calculate something which is called creatine calcium clearance ratio. If it's more than 3%, or some guidelines 2%, it is primary hyperthyroidism. If the ratio less than 2%, it is familial hypercalcemia, hypocalciuria, and between 3 to 2%, there is a borderline. Most of the patients, they have vitamin D deficiency. We correct it or replace it, then we repeat it again. In other group, PTH, non-PTH mediated hypercalcemia. The second step in this group, we have to measure PTH-related peptide and vitamin D. PTH-related peptide, this hormone usually secreted by the malignant cell. It was described first time in 1947. They found there is some factor like PTH causes same presentation of hyperparathyroidism, but with low PTH, but was detected in 1987. PTH it works in the same receptors of PTH in the kidney, in the bones, causes high calcium level, low or normal phosphorus level, and low PTH level. So if PTH-related peptide is high, so that means patient had malignancies, mainly squamous cell carcinoma in the lung or breast cancer. If PTH-related peptide is not detected or is low, usually we check 125 dihydroxyvitamin D and 25 hydroxyvitamin D. If 25 hydroxyvitamin D is high, this is vitamin D intoxication, calcidol. If 125 dihydroxyvitamin D is high, that means differential diagnosis include calcitrol intoxication, like 1-alpha or oxy-alpha overdose from that. Or patient may have granulomatous disease or lymphoma, like granulomatous disease like sarcoidosis or TB, because the macrophage in the granulomatous tissue and some malignant cell in lymphomas can overexpress 1-alpha hydroxylase enzyme, which converts inactive vitamin D to active vitamin D, and result in hypercalcemia and hyperphosphatemia also together. If PTH-related peptide is low and vitamin D is normal or low, so differential diagnosis: multiple myeloma, vitamin A intoxication, milk alkali syndrome, thyrotoxicosis, and immobilization. Except some cases, Primary hyperparathyroidism is considered the most common cause of hypercalcemia, especially in elderly women more than 65 years. Treatment of usually patients present with high BTH or normal BTH, mild hypercalcemia, normal or low phosphorus, and high calcium in the urine to differentiate from familial hypercalcemia, hypocalciuria. Treatment of hyperparathyroidism is parathyroidectomy, but not all cases of hyperparathyroidism require treatment or surgical approach. The guideline recommend to do or send patient for parathyroidectomy if the age of patient less than 50. If more than 50, age more than 50, usually you send patient for parathyroidectomy if they have hypercalcemia, calcium level more than 1 milligram per deciliter above the reference range, or if there is osteoporosis or fracture, or if there is kidney stones or hypercalciuria, calcium in 24 hours urine more than 400 milligram, or if there is renal failure, the creatinine clearance less than 60 milli per minute. Otherwise, if patient doesn't match this criteria for parathyroidectomy, we monitor calcium level in the blood, in the urine, 24 hours, kidney stones, DEXA scan every year. Without treatment, people who are not matching the criteria for parathyroidectomy, without treatment or surgical treatment, around 30% will develop a complication of hyperparathyroidism and require parathyroidectomy over 15 years. And we cannot predict who patient will require treatment in the future. So for that reason, we monitor every year. In familial hypercalcemia, hypocalciuria, we talk about it. Malignancy-associated hypercalcemia. It's estimated to affect around 2.7% of people with cancer in the USA. In the UK, the prevalence of malignancy-associated hypercalcemia is 0.67%. The prevalence estimates varied across cancer types and are highest for lung cancer, multiple myeloma, and patients with stage 4 cancer with bone metastasis. Mechanism of hypercalcemia in malignancy, around 80% of patients, their hypercalcemia is mediated by parathyroid-related peptide. In very rare cases, some neuroendocrine tumor secrete parathyroid hormone. In lymphomas, usually we see elevation in 125 dihydroxyvitamin D, and in 20% of hypercalcemia with malignancy, the mechanism is local ulcerations related to the metastasis. However, the median duration of survival for patients with malignancy-associated hypercalcemia is only 2 to 6 months from the onset of hypercalcemia. So the hypercalcemia with malignancy is a poor prognosis sign. Lithium-induced hypercalcemia. Lithium, usually we use lithium to treat people with bipolar. And lithium, it's known to cause hyperparathyroidism, hyperthyroidism, and nephrogenic diabetes insipidus. Lithium can present with the same picture of primary hyperparathyroidism, hypercalcemia, hypophosphatemia, and high PTH. How we can differentiate between them? Actually, there's no way to differentiate between lithium-induced hypercalcemia and hyperparathyroidism, only to stop the medication. If it is safe to stop the medication, it's better to repeat high calcium level after 2 to 3 weeks. If it's still high, it's better to send patient for parathyroidism, and the diagnosis it's primary hyperparathyroidism. If we cannot stop the medication, usually we monitor the calcium level. If patient doesn't have symptoms, only keep monitoring. If patient have symptoms, it's better to send patient for parathyroidectomy even without clear diagnosis of primary hyperparathyroidism. Thiazide, it causes hypercalcemia and hypocalciuria. And it can mainly it's present with normal PTH, sometimes with high PTH, and it's very rare to present with low PTH. It works in the parathyroid gland and in the kidney gland. The most important in thiazide-induced hypercalcemia to reduce the calcium level after 2 to 3 weeks from discontinuation of the thiazide drug. Because thiazide can stimulate hyperparathyroidism. In this study, we can see around 70% of patients after discontinuation of the thiazide, they continue with hypercalcemia, and around 60% of them, they diagnose primary hyperparathyroidism. So it's not enough to stop this medication. We have to monitor to rule out potentially hyperparathyroidism. Endocrine disorder, we have hyperthyroidism because the thyroid hormone, it works in the osteoclast and increase the calcium and phosphorus. Pheochromocytomas sometimes present with hyperparathyroidism as part of MEN2, or some pheochromocytomas secrete PTH. Acromegaly, it enhances PTH, works in the kidney and bones. In Addison disease, sometimes we see high calcium, but it's not related to the Addison disease. It's related to dehydration, which is symptoms of Addison disease, or it's related to underlying cause of hypocortisolism like TB or lymphomas. Treatment. First line of treatment is hydration. Emergency treatment includes aggressive intravenous hydration with 3 to 4 liters of normal saline daily, or 1 to 2 liter bolus of normal saline followed by 200 to 250 milli saline hourly. This type of treatment is active in only 30% and normalize calcium in only 30%. Life-threatening hypercalcemia is indication for hemodialysis. Loop diuretics. Actually, this is common practice, and for long time, Lasix or forceamide has been used to treat hypercalcemia. Till 2008. In 2008, in 2008, there was a very important and very big review. They review all published reports of furosemide in hypercalcemia treatment. All the reported articles from 1950 till 2008. They found only there is 39 reports, and all its case reports. There's no studies. And they found that normal calcemia achieved only in 50% of the patients, and normal calcemia achieved in first 12 hours in only 2 patients. And the dose to achieve normal calcemia of Lasix, it's around 1,000 milligram per day. So that dose, like 60 milligram, 80 milligrams, is not effective to treat hypercalcemia. In other hand, they found that this type of treatment will increase hypernatremia, increase hypomagnesemia, hypophosphatemia. So it's increase all the complications. So after this review in guidelines, there's no more recommendation for loop diuretics in hypercalcemia treatment. Bisphosphonates, it works in extracellular and intracellular space, actually. In extracellular space, bind to calcium phosphate and stabilize the bone matrix. While intracellular space, these agents inhibit osteoclast activity and induce apoptosis. Studies showed that 4 milligram of zonuroic acid or Zumita will normalize calcium level within 3 days in 80 to 100% of patients. FDA approved zonuroic acid, approved bimodronate to treat hypercalcemia, but we cannot treat it in patients with creatine clearance less than 30. Bimodronate evaluated for hypercalcemia, and it's effective, but it's not approved by FDA, and we can use it in people with kidney failure. And potentially, we can use any type of bisphosphonate, but this is only an IV form from bisphosphonate. Denosumab or Prolia is a fully human monoclonal antibody that binds to rank ligand. Actually, parathyroid hormone, it works in the osteoblast. It binds to the receptors and stimulate osteoblast to secrete something which is called rank ligand. Rank ligand will bind to rank receptors in osteoclast and activate osteoclast and increase the number of osteoclasts, and that causes hypercalcemia. So the denosumab or Prolia, it works in the rank ligand in osteoclasts and inhibits the maturation, activation, and function of osteoclasts. It could be given even in people who have kidney failure and creatine clearance less than 30 milli per minute. The dose is 120 milligrams subcutaneous in day, first day 8, 15, and 29th day, then every 4 weeks. And it normalizes the calcium level in 64% within 10 days. There's some concern about Prolia to increase, they thought it increased the severe infection because rank ligand is expressed on B and T cells. But FDA reported that only a slight increased incidence of serious infection, around 4.1% with denosumab and 3.3% with placebo. So it is safe and doesn't cause any serious infections. Calcitonin is a peptide hormone secreted by C cell in the thyroid gland and inhibit osteoclast also and increase urinary calcium excretion. It's given by 4 to 8 units per kilogram intramuscularly or subacute every 8 to 12 hours. Calcitonin has a rapid onset of effect and lead normalized calcium level in 2 to 6 hours after the first dose. But it has poor efficacy. It's normalized calcium only in 30% of patients, and the repeated administration of calcitonin result in downregulation of the calcitonin receptors in osteoclasts and reduce the effects. So after 3 days of administration of calcitonin, there's no benefit to continue with this type of treatment. Usually we give first dose of bisphosphonate because we know that bisphosphonate take 2 to 3 days to work. We cover this gap with calcitonin in patients who have severe hypercalcemia. In vitamin D intoxication, we know that in granulomatous disease like TB, sarcoidosis, or lymphomas, already we know the mechanism of hypercalcemia is vitamin D intoxication, especially 125 dihydroxyvitamin D. So the treatment will target the metabolism of vitamin D and increase the metabolism of vitamin D because the half-life of vitamin D is very long, around 2 to 3 weeks in the body. So usually we treat this type of hypercalcemia with prednisolone or steroids. There's no guideline about the doses and administration, but in general we give hydrocortisone IV 200 to 300 milligram per deciliter for 3 to 5 days. Then we maintain it by prednisolone orally between 10 to 30 milligram per deciliter. Sometimes second line of treatment, ketoconazole also. It's increased the metabolism of vitamin D because vitamin D is stored in the liver and takes 2 to 3 weeks for clearance. So how we can? It's in cytochrome also it works. Cinecalcit. Cinecalcit is a calcium mimetic actually. It activates the calcium sensing receptors in the kidney and the parathyroid. Cinecalcit has recently been approved for the reduction of hypercalcemia in patients with parathyroid carcinoma or people who have tertiary hyperparathyroidism or secondary hyperparathyroidism or people who have primary hyperparathyroidism and there is no rule of surgery in this type of patients. It has no effects on other features of primary hyperparathyroidism. It works in the calcium serum only. It doesn't change the prognosis of the osteoporosis or calcium in the urine. It doesn't reduce the stones in the kidneys. Cinecalcit given orally in dosing regimen between 30 to 120 milligram per deciliter. There are no clinical trials of cinecalcit in malignancy-associated hypercalcemia. There's only 3 published cases showed that malignancy-associated hypercalcemia refractory to bisphosphonate with or without denosumab therapy, calcium level were successfully managed by cinecalcit. Till now, there's 5 patients with lithium hypercalcemia have been described who have received cinecalcit with subsequent improvement in hypercalcemia during the therapy. In summary, approximately 90% of people with hypercalcemia have primary hyperparathyroidism or malignancy. The most important initial test to evaluate hypercalcemia distinguishes PTH-dependent from PTH-independent causes. Mild hypercalcemia usually doesn't need acute intervention. Initial therapy of symptomatic or severe hypercalcemia, hydration, and IV bisphosphonate. In patients with kidney failure, denosumab and dialysis maybe is indicated. The prognosis of asymptomatic primary hyperparathyroidism is excellent with either medical or surgical management. Hypercalcemia of malignancy is associated with poor survival. Thank you.